Thanks, friends, for watching my education channel for medical students. I will repeat that this channel is dedicated to medical students, and the um, data and the information available are suitable for medical students. And as I always emphasize, that we will keep it simple and concise and avoid the controversial issues that can be confusing. Today, I decided to talk to you about Cushing syndrome. Now, with Cushing syndrome, we know that the adrenal gland has got an adrenal cortex and adrenal medulla. And the adrenal cortex produces glucocorticoids and mineralocorticoids. The mineralocorticoids are mainly the aldosterone, and we spoke about the aldosterone secreting adenoma and Cohen's syndrome in a previous lecture. And today we will talk about excessive cortisol secretion. Now, cortisol does have a very important physiologic function. It affects almost every aspect of metabolism in the human body, including the homeostasis of the cardiovascular system. Cortisol level particularly can go up, and because they are necessary for survival. They will go up if there is a trauma or there is stress, regardless of the type of the stress, whether it's physical or mental. If someone have surgery, anesthesia, any form of trauma, any sort of trauma, will activate the hypothalamus pituitary adrenal axis, where the hypothalamus will produce the corticotrophin that stimulates the pituitary gland to produce the ACTH, the adrenocorticotrophic hormone. And the ACTH works on the adrenal medulla to produce cortisol. This axis is controlled by a well-controlled feedback mechanism. So cortisol helps us metabolize carbohydrates. So in order for the insulin to be able to maintain your blood sugar within normal limits, it will need cortisol to work mainly on the liver and probably on the adipose tissues to work on a gluconeogenesis process. It also affects the metabolism of lipids and proteins. Cortisol is also very essential for the maintenance of the vascular tone and the endothelial integrity of the cardiovascular system. It's important to facilitate the vasoconstrictor action of catecholamines. So the absence of steroids will lead to vasodilatation because we will lack the permissive effect of cortisol to allow catecholamines to constrict the arterioles. It also has anti-inflammatory system and used as a medicine in various inflammatory problems such as rheumatoid arthritis and ulcerative colitis and variety of autoimmune disease. So it has a strong immune suppressive function, which is related to the dose of the steroids. So you can see in the absence of steroids, if we don't have cortisol in our system, it will lead to a problem which is called hypoadrenalism, or the Addisonian crisis, which is characterized basically by hemodynamic instability in the form of low blood pressure. Also, the glucose level will go down, potassium level will go up, we'll get hyperkalemia, and the patient can soon become unconscious. That's all well and good, but excessive steroids can be problematic as well and can lead to a disease that is pretty serious. Now, Cushing syndrome was first described in 1912 by Harvey Cushing, who describe the excessive secretion of corticosteroids and what it leads to in the form of obesity and diabetes, hypertension, and other metabolic problems. Now, we should differentiate between Cushing disease, Cushing and syndrome. Cushing disease is where you have got an ACTH producing pituitary adenoma. Usually it's a microadenoma, and they are mostly around 4 or 5 millimeters, and sometimes they are very difficult to detect on imaging. While Cushing syndrome is caused by an adenoma in the adrenal cortex that produces excessive cortisol, and it's outside the control of the hypothalamic pituitary adrenal axis. So it is independent and secretes cortisol on its own in the absence of ACTH. Very small percentage of the Cushing syndrome can be caused by ectopic ACTH secretion, and this is usually either from a neuroendocrine tumor of the gastrointestinal tract or a bronchogenic carcinoma. Usually the small cell carcinoma is the culprit, and in these situations it is a paraneoplastic syndrome that produces a protein similar to the ACTH that lead to excessive cortisol secretion by the adrenal gland and the clinical manifestation of the Cushing syndrome. Now, Cushing syndrome is, and if untreated, it's a lethal condition, and it's associated with 5-fold increase in mortality, and most of the mortality is caused by cardiovascular complications and diabetes and its consequential effects on the cardiovascular system, the kidney, and the nervous system. Now, how do they present clinically to you? Usually there's a long history before these could be discovered. I've got a picture for you here, which is an extreme condition where you can see what we call the striae of the skin, pink striae of the skin, as a result of the excessive cortisol work on the collagen system that would lead to thinning and weakness of the connective tissue. These patients are characterized by truncal obesity, and their appearance is unusual. The legs tend to be very thin, and the trunk is quite obese. They will have hypertension. They will be diabetic. There is a lot of muscle weakness. They can get easily bruised. They could get hirsutism and facial plethora. But the diagnosis really gets suspected most of the time by the truncal obesity and what is called also the moon face, where the facial fat is very prominent and rounded. Also, a lot of accumulation of fat on the shoulders, which looks like a hump on both shoulders, in addition to the skin changes and the rest of the metabolic changes. Usually they go for a long time before the diagnosis gets suspected and further investigated. So now we have suspected the diagnosis based on the clinical appearance of the patient, and then we move on to how we make the diagnosis, what sort of investigation we will request for them. Now, the entire diagnosis will rely on confirmation of inappropriate cortisol secretion. So we need to do serum cortisol and ACTH. So if we have got an adrenocortical adenoma that is independent and secretes excessive cortisol, the ACTH will be inhibited, and usually it is undetectable. We could also do evening cortisol level in a salivary sample, which proved more likely to be very sensitive and specific way to diagnose excessive cortisol secretion. So elevated cortisol level in a salivary sample in the evening before the patient goes to bed can be quite helpful. We could do 24-hour urinary cortisol secretion, and that can confirm excessive cortisol production. And if we are not sure about the diagnosis, we might need to investigate the patient a little bit further. Now, putting the numbers together, if we have a bedtime cortisol level of more than 550 nanogram per deciliter, is 100% specific for Cushing syndrome. So if it is higher than this level, so I'm saying the bedtime cortisol level, if it is higher than that, it's 100% specific for the diagnosis. It means that you actually secured the diagnosis of cortisol excessive secretion. Now, that a lot of times it can be the results of all the tests can be inconclusive, and if we are still suspecting the possibility of Cushing disease, we could do further investigation. Obviously, high ACTH indicate that there is either a pituitary adenoma or extra adrenal, extra pituitary ACTH production from tumors. So when we have high ACTH, that will shift the diagnosis from adrenal cause to a central cause in most of the cases, which is more common, in fact, clinically. As I said, if we have adrenal adenoma that secretes excessive cortisol, then the ACTH will be usually undetectable. We do face sometimes certain cases where the results are indeterminate, where the ACTH is detectable and still cortisol levels are in the high level. Then 24-hour urinary cortisol secretion can actually help us. And also we can do a dexamethasone suppression test. And the dexamethasone suppression test is useful because it will suppress the ACTH secretion if it is coming from a pituitary pituitary adenoma. It may not have any effect on the extra-adrenal or the inappropriate ACTH production from tumors. We manage these cases all in conjunction with our endocrinologist, and we escalate the test according to the situation. But the basic things that we could start with is the set that you can see in this slide. So the serum cortisol and ACTH, and then if there is suspicion, we could do the evening cortisol in the saliva or the bedtime cortisol, and that will help us to see if the cortisol is actually elevated. And we look at that in conjunction with the level of the ACTH, and then we direct our imaging and further investigation according to that. Obviously, Cushing disease or pituitary adenoma is more common cause than adrenal adenoma for Cushing syndrome. And in this situation, if we have a high ACTH, we do an MRI scan for the brain and the pituitary gland. And as you see in this case, there is a pituitary adenoma on the MRI. And in that case, this will be referred to the neurosurgeon for resection of the microadenoma. Now, unfortunately, only 50% of the adenomas will be detectable on the MRI because they can be quite small, less than 4 millimeters, and it's under the resolution of the imaging. So if we don't find that and we think it might be the adrenal, that's the cause of the excessive secretion, then we do a adrenal protocol CT scan looking for adrenal adenoma, and we can further do the dexamethasone suppression test, and it will help us to determine the source of the excessive cortisol, whether it's central or from the adrenal gland. If it is central, we do the high dexamethasone suppression test, which is 2 milligrams 6 hourly for 48 hours, and then we do the levels of ACTH and see if the ACTH is inhibited or not. So the main benefit of the dexamethasone suppression test is to detect an adenoma in the pituitary gland that will get suppressed by this test in case where the lesion is not seen on MRI. And in that situation, we need to focus on the pituitary gland for the treatment, whether it's medical or surgical, according to the condition of the patient. Now, I thought I'd show you this, which is very important. That's how the patient appears if they have got Cushing syndrome, regardless of the cause. So they get variety of symptoms and variety of syndromes. Steroids will affect almost every single organ in the body. So if we start from the head, they will get neuropsychiatric disorder, usually in the form of anxiety, euphoria, depression, and manic attacks because of the excessive steroid secretion. It will work on the cardiac muscles, and that will lead to weakness in the cardiac muscles and cardiomyopathy. It will lead to excessive and rapidly progressing atherosclerosis in the arteries. It will lead to fatty infiltration of the liver and steatosis, and that can, which will be similar to the metabolic syndrome that we will get in patients with morbid obesity. Osteoporosis is very common, and spontaneous fractures are problematic, particularly in the spinal cord and in the femur. Fertility will get affected. The patient will have visceral obesity with excessive fat deposition in the omentum and the mesentery. Their immunity will be suppressed, so they get easily can get infections, particularly in the peripheries of the skin. Myopathy will lead to generalized weakness, and so on and so forth. So it's very morbid syndrome to have if the diagnosis is delayed and treated. Now, if we are still sometimes we have doubt about the source of the excessive cortisol secretion, and then we might resort to the sampling of variety of veins, which will include bilateral adrenal vein sampling, as we saw in the aldosterone secreting adenoma, to see if we can find excessive cortisol on one side. And if that proves the case, then we remove that adrenal gland, whether it's the left or the right. Every now and then we see we could be looking at ectopic ACTH production, and in that case, we need to do CT chest, abdomen, and pelvis, looking for either lung cancer, small cell carcinoma, or neuroendocrine tumor of the gastrointestinal tract or the pancreas. Chromogranule level can be useful in those situations if we are thinking about neuroendocrine tumor, and gallium PET is now the best investigation tool in terms of nuclear and metabolic imaging for neuroendocrine tumor. In the past, we used to do octreotide scan for them, and it's still in use in certain centers. So it can be a dilemma to localize the source of the excessive steroid secretion, but eventually with the combination of the imaging, the sampling test, even sampling the venous system in the brain, the petrous sinus, or one of the petrosal sinuses, can be done with an experienced radiologist to see if there is excessive production of ACTH from the pituitary gland. As far as the treatment is concerned, when the lesion is located in the adrenal gland, then we do laparoscopic adrenalectomy, and you can see in the picture how it get done. This is the head of the patient to your right side, and the feet to the left, and the mark here is the subcostal, the right subcostal margin, and you see the surgeon here has got 4 ports in the abdomen, which we use an optical, what we call an optical entry and a direct vision, and we get to the peritoneal cavity. This is transperitoneal approach, which is my favorite approach for adrenalectomy. And then we get pneumoperitoneum, and then we use 2 extra or 3 extra ports for the work and the retraction. And the operation usually is straightforward. It takes about an hour and a half, depend on the body habitus of the patient, and so on and so forth. The benefit of that, it's if we find adenoma in the adrenal gland, it's curative. Surgery is curative. Usually these patients have their adrenal gland, the other contralateral adrenal gland, very suppressed. So they will need perioperative hydrocortisone. Otherwise, they will go into Addisonian crisis. And we should be aware of the symptoms of the Addisonian crisis. As I said in the previous slides, they get hypoglycemia, they can deteriorate to become unconscious, and usually hypotension and hyperkalemia are one of the first signs that you see on their blood. And obviously low cortisol level. So we need to cover the perioperative period with hydrocortisone, and then once they are day 1 or day 2, we measure their serum cortisol, and then we keep them on a tapered dose of prednisone along with the endocrinologist. Usually this is guided by the endocrinologist, and they might need to be on the steroids for a long period of time. That can vary between 3 to 12 months. The longer the gland have been suppressed, the longer it will take to recover the contralateral adrenal gland. They are at high risk of DVT, so we should be aware of DVT prophylaxis, which starts from when the patient's on the table with TED stocks and cloxane and pneumatic compression of the calves during the operation. We give them some antibiotic prophylaxis around the time of the operation. Then we check their cortisol in the post-operative period, and then we hand them back over to the endocrinologist to look after their metabolic issues. Usually, if it is an adrenal lesion, it is curable, and they can be taken off the steroids in due time. And their metabolism and the rest of the effects of the steroid on different parts of the body will improve. Thank you very much for staying with me and seeing this video, and keep tuned. There will be more and more videos, and I will try to cover most topics that are of interest to you with regard to the discipline of general surgery. Thank you very much, and I will see you in the future.